I am very delighted to introduce Dr. Christine Moutier as our keynote speaker, who will be addressing suicide prevention. Dr. Christine Moutier knows the impact of suicide firsthand. After losing colleagues to suicide, she's dedicated herself to fighting this leading cause of death. Dr. Moutier has worn a lot of hats: practicing psychiatrist, professor of psychiatry, medical school dean, medical director of an inpatient psychiatry unit. As a leader in suicide prevention, Dr. Moutier joined the American Foundation for Suicide Prevention in 2013 as their chief medical officer, which is where she is today. Her work has created lasting impact through research, education, advocacy, and support. In addition to many scholarly contributions, Dr. Moutier has testified before Congress, presented at the White House, provided congressional briefings on suicide prevention, won many awards, co-anchored CNN's Emmy Award-winning Finding Hope Suicide Prevention Town Hall, and provided expert commentary from many media outlets. I'll go ahead and stop there so I don't take too much of her time. There's much more that I could say about Dr. Moutier. We're very fortunate to have her give us a broad view of the field of suicide prevention, where we are, where we're going, where we need to be. With that, I'll go ahead and turn it over to you. Thanks so much for joining us here.
Thank you so much for that wonderful introduction and for the invitation to be part of this conference. So I will be speaking from the standpoint of really what's going on in the suicide prevention national arena related to some current scientific findings, how culture is changing around the application of some of these findings, and really end by talking about some of the both community-based and clinically based suicide prevention efforts that are evidence-informed. And so I really am not a super expert in the niched area around use of technology, but I'm going to try to have a constant sort of lens on that topic as I go through my comments, so that hopefully, my goal is really to engage all of you to become interested and help our field ask the right questions to apply technology in the ways that we know can make a difference, but obviously needs evaluation in order to know for sure what works when it comes to suicide prevention. My main disclosure is that I do work full-time at the American Foundation for Suicide Prevention, and we have one program called the Interactive Screening Program that is licensed to organizations, universities, workplaces, and EAPs, and AFSP does receive the license fee for that, but I do not. But it is it is an AFSP product, so to speak. And I also released a book published by Cambridge University Press last year on the topic of suicide prevention. It's written with clinicians in mind for the most part, with an emphasis on primary care, actually, but of course for mental health professionals and really anyone who's interested in learning more about the latest in the field of suicide prevention. So over the next 30 minutes or so, I'm mainly going to divide my time up in, as I mentioned, talking about some of the recent trends, again, scientifically, but also just more societally. We'll do a very quick tour through what does science tell us to help us understand what drives suicide risk and what constitutes effective prevention. And then we'll end on prevention strategies. So just kind of taking a deep breath and thinking about where we are in this, whatever we want to call it, moment in 2022, whether we think of it as post-pandemic or with some transitions happening with regard to our, not only, the pandemic itself in terms of the viral impact, but thinking about all of the societal impacts with an emphasis on mental health and suicide. I've thought about so many things that might seem to be outside of those specific lanes of mental health and suicide risk, but so much does impact suicide risk for an individual or for a population that it's important that we actually think about all of these different types of experiences that I won't detail out here which of course, none of us are necessarily directly experiencing all of these, but different people groups and different families are experiencing a number of them. All of us have had our lives kind of upended, at least in some fashion. And probably more of us actually know people whose lives have been significantly impacted, either through the loss of someone that we know, through the loss of a job, through financial strain, all of those things. And so I look at human behavior from the standpoint of the multitude of influences, both internal and external, that affect our outcomes. And we're seeing behavior changes. We're seeing some norms change in some really detrimental ways, just in terms of polarization and sort of general unrest and maybe a tendency towards more adversarial assumptions about each other. And those are not good things for us as human beings, and they're not good for our sense of human connection either. So now, long before the pandemic hit, we know that it's been a time where stigma has been decreasing and diminishing very, very robustly by many different measures. Of course, that doesn't mean that every family and every community within our nation are adopting the same views in the same way or at the same speed, but we saw that attitudes opened up even more during the pandemic to be able to talk about the distress we're in, because it had become so very universal. And during May, Mental Health Awareness Month, our organization, along with some others, took a full page ad out in the New York Times. The theme around May Mental Health Month for AFSP was this theme of policy, action, demanding more for mental health. So it is a time where I think the public's will has become quite aligned with mental health advocacy and the need for suicide prevention. And I will say, working in the space, there are lots of silver linings to working in the field of suicide prevention. But one of them is that it is one of few, mostly still bipartisan issues when it comes to working in the policy arena. Now at AFSP, we have been kind of keeping tabs on these changes in attitudes. And you can see that in the most recent poll, we poll the American public every couple of years with some other organizations. With the latest one just a month or two ago, it showed that 92% of American adults view their mental health as or more important than their physical health, and most of them understand that suicide can be prevented, but they also pointed out many different deficiencies, either in their own knowledge and skill of how to approach someone that they're worried about, and then also difficulty accessing care was a theme in that most recent poll. But it is also true that more Americans than ever before are seeking mental health services or peer support or help through the use of an app or some other technology-based, entity. Another kind of just little measure of changes in culture and attitudes are the number of people talking about their suicidal experiences or their mental health struggles or the loss of a loved one to suicide. And all of these folks here have been doing that in different ways over recent years. And if you're paying attention, if you have the lens that I have, you'll know that there are just a multitude of people who are talking about different aspects of their mental health experiences or their families, or working it into their work in some way. Taking a look at US suicide rates, however, we know that going all the way back to 1980, and of course we could go back even farther, but just to show that from about 2000 to 2018, there was a steady uprising trend in the national rate of suicide for a total of a 36% increase in that nearly 2-decade period. Then there were 2 consecutive years of a downgoing trend, which was, of course, very hopeful and wonderful to see that. We do know that the CDC's provisional data for 2021 is unfortunately showing a 4% increase in the national rate. during COVID, there were lots and lots of concerns, as appropriately there should be, about the ways that the impact of the pandemic and all of the indirect aspects of the pandemic might impact population suicide risk. And in a series of papers that I contributed to, and one that I did an invited paper for JAMA Psychiatry, we outlined these sort of buckets of potential stressors or experiences that could negatively press upon population suicide risk. And here, through these green checks or red X's, I've just given a rough sort of my opinion about how we did as a nation. And of course, this has to do with policy in large part, but also organizational leadership and the openness or the proactivity around addressing things like the fact that there was, so much more concern about isolation, feeling of loneliness, grief and bereavement, the access to lethal means with first-time gun owners, I think going up more than ever before in history, alcohol consumption being on the rise for most of the whole population, but specifically for those with suicide risk, that could be, a real negative in terms of additional risk. We know that opioid overdose deaths were at an all-time high in 2020, and that has a relationship to suicide risk and prevention as well. So we at AFSP, we do have the opportunity to work a lot with media, and it's not that I think they're all doing a great job. That's why the kind of smaller green check is that what I mean by that is that we are seeing some of the leading outlets, when they come to us now, they come to us not with, just can we interview you and get into the weeds on something, or without a concern about sensationalizing the topic. Especially after a death has occurred, we oftentimes get the question, how can we use this moment for good from a suicide prevention standpoint? And so the intent is there, the execution isn't always perfect. And of course, not all outlets are necessarily undergoing these progress that we're seeing that some are. So I want to talk a little bit about how we can address suicide, but first it's really to establish, how do we understand suicidal behavior? And so again, this will be the whirlwind tour of a very growing and complex science around suicide risk and protective factors. But what we know is that there are well-established risk and protective factors. Risk factors being much more well-established actually than protective. This is hard science to conduct, and particularly the fact that it's never one risk factor. It's never even two. It's always the convergence of, usually between, on psychological autopsy studies, we see that it's between 5 and 9 that are identifiable risk factors that are sort of converging and interacting in the period of time leading up to the person's either attempt or suicide death in the case of psychological autopsy. And you can put the buckets of risk factors and protective factors into these biological, psychological, social, environmental. And one of the main takeaways here is that it's not just life events that cause somebody to become suicidal or to act on their suicidal thoughts. It's oftentimes we consider current stressors or losses as precipitating events on a bed of already present risk factors. And of course, protective factors are, as they are called, protective, but during periods of crisis, even those protective aspects of coping and flexible thinking and problem solving and social connectedness can get dismantled temporarily, so that people in that acute moment of crisis may, although they may have normally very close ties with friends, family, coworkers, they suddenly feel disconnected, as one example. Or, people who've developed more flexible and very self-aware coping strategies with things like cognitive behavioral therapy, there can be we think of a sort of cognitive constriction in the moment of acute risk, where that flexibility becomes more rigid and that tunnel vision ensues. So it's a complex, interactive, very dynamic situation. And of course, access to lethal means has a lot to do with an individual's as well as a population's suicide risk. So some of the top scientific findings, as I've been kind of already highlighting maybe a couple of them, is, again, suicide risk is highly multifactorial and dynamic. That mental health mental health conditions are an almost sufficient but or almost necessary but insufficient risk factor. That it's oftentimes you can have, unaddressed or only partially addressed depression, anxiety, PTSD, addiction, eating disorder, personality disorders, but again, they're not in a vacuum, thought to be creating suicide risk on their own. It's when there are other factors like the genetics, the field of genetics around suicide risk is actually showing that it's a highly, again, complex interaction there, but that that the genetics for suicide risk certainly overlap with the genetics for psychiatric conditions, but not entirely. That there are other factors like aggression and other aspects that can be in part genetically influenced. Epigenetics matters very much, and is the fact that when there is, let's say, early trauma or current trauma, that there can be I look at it as laying a log down on the tracks of your DNA so that the expression into proteins is changed, even though the DNA itself is the same. But then conversely, therapy, social connection, and other evidence-informed suicide prevention strategies can conversely produce different outcomes and probably through epigenetic mechanisms as well. Culture matters, so belief matters a lot, and that's why I'm talking about societal kind of culture change with stigma going down, because it is known that in populations where there's a high amount of stigma related to mental health experiences and a high amount of stigma related to help seeking, and where leaning on others is not the norm, but where self-sufficiency is much more the rule, those are problematic. Those create additional risk and actually can thwart otherwise effective suicide prevention efforts. I mean, there's a lot more we can talk about here. I think suicide contagion is a real phenomenon. And so you do hear a lot about that, but I think sometimes people are getting confused to think that means that it's not safe to ask someone who is struggling in your own life if they are thinking of suicide. And those are very, very separate phenomenon. Contagion has to do with after a peer dies by suicide or attempts, or after a celebrity has died, and how the aftermath is handled by media in the case of celebrities, or by a school leadership or workplace leadership after a student or a coworker were to die by suicide. So postvention is essentially the mitigation strategy to mitigate contagion risk. And it means that the leadership and also media have a role to play in facilitating healthy grief and access to mental health resources, and really keeping their eye on the potential risk of suicide contagion. And that is a complicated and imperfect sort of strategy, but it can make a huge difference. And it does involve things like monitoring social media, as well as guidance around communication strategies. It's the aftermath of suicide really is, you can look at it as a crisis management type of situation where a team needs to be ready to go to manage that period of time, and probably really stay on top of it closely for a period of days to weeks in order to really do a maximal job with mitigating contagion. Effective mental health treatment is one of the most preventive strategies, particularly for high risk populations. So that means if certainly anybody who's been diagnosed or who has yet to be diagnosed with a mental health condition, almost every mental health condition has been shown to be associated with higher degrees of suicide risk. And again, it doesn't mean on its own, and it doesn't also mean that that's fate. It means that just like if you get diagnosed with high blood pressure, or like, let's even talk about genetic loading a little bit. If you have a family history of early mortality due to heart disease, and now you're getting diagnosed with hypertension, you probably know something about what that means about keeping your sense of cardiac health and overall health maintenance a little bit more vigilant, and making choices perhaps that are informed a little bit by that. And that's what we're trying to do with suicide prevention education for the general public, that ultimately that mental health literacy will actually guide what we can do for ourselves, for our family members, for our colleagues. And now later in the talk, I'll even show you what workplace leaders are doing around suicide prevention. So it's this incredible time of trying to translate this very complex and growing body of scientific investigation, but where there is clarity around findings, to translate that into action and not just wait for more science. So it's AFSP is really sits in that seat of being the leading private funder of probably all suicide-related scientific activity. Again, private funder. So the NIH is doing a great job with that as well. But in terms of the private space, AFSP leads the way. But because we have our chapter network and partnerships that I'll show you in a moment, we do have this incredible opportunity to be involved in the translation and dissemination of the science. So I think all of that complexity in the backdrop, what we can clearly understand based on all of it put together is that while complex, suicide is a health issue. And that is a change from the way we had understood suicidal behavior in the past. This also means that we can apply a public health framework to the issue of suicide prevention from a population health standpoint. That means universal strategies. That means more targeted and selected strategies need to be developed and studied. Of course, treatment and intervention, and then also recovery matters very much. There is a strong advocacy voice in the suicide prevention field that is no longer only made up of families who are loss survivors, but are now including people who are speaking out, including myself, about their own lived experience, which means that they might have had a suicidal crisis. They might have attempted suicide and survived. Or even more upstream ways of suffering. We include the lived experience term to be quite broad, a very, very broad umbrella. But, thinking about all of these levels, that there's really kind of, in a way, a role for all of us then to play in suicide prevention. If you're on the scientific side, if you're a clinician, if you're a family member, if you're an educator or a workplace leader, this public health framework can guide us. Now, every nation that's had a successful or more full maximal implementation of their national suicide prevention strategy has included a very robust crisis response system. We know that 988 just launched as the 2.0 version of the National Suicide Prevention Lifeline just a few months ago in July. And the thing is about 988 is that, yes, it is a rebrand with this simple to remember number, but much, much more than that. It is creating an infrastructure and a mental health system of response that goes way beyond the acute crisis moment, that's trying to build things like mobile crisis teams, respite centers, peer support units that will bridge the gap between an acute crisis and the only place to take a person who's in a suicidal crisis being, in some communities, it's still to the emergency room, where or even thinking about moving away from a law enforcement response to mental health crises. We've known for a long time that it was built in a different time and quite leading to all sorts of unintended outcomes, and we need to rectify that. And there are incredible models going on all over the country with new ways to only engage with law enforcement when absolutely necessary. And so, for example, since the launch of 988, we know that the volume of calls and texts and chats went up, more than doubling, and the wait time actually has gone down. So the investment that Congress has made, which is the all-time highest investment our country has ever made, by the way, $400 million into the mental health system, and into suicide prevention. So that is good, but even more importantly, things around, again, this issue of in the rare event that someone requires more than just the call itself with the resources and referrals given, it's less than 2% of the time that there's something imminent that's threatening safety where 911 would need to be involved. And in those instances, again, the build that's happening now at the state and local levels is to ensure that it is a mental health response that would show up in person. So there are, based on, science and some of that translation and now what we call implementation science activities, I've kind of put together all of the top line evidence-based or evidence-informed suicide prevention strategies that, for example, the CDC includes in their technical package on suicide prevention, and SAMHSA, the Suicide Prevention Resource Center, NIMH, my organization, we can all agree that these constitute sort of the most important suicide prevention strategies that we really should need to think about at the community level. So things like, of course, shoring up our access to mental health care and infusing these new suicide prevention steps into healthcare, because that has yet to be done largely yet. Increasing interpersonal connectedness, anything that one can do in a workplace or a school or a faith community. Reducing access to lethal means, that of course has tremendous policy, but also educational sorts of ramifications. And just kind of skipping ahead here, focusing on equity and including the voice of people with lived experience, so that science is constantly, the best studies are actually, they include as part of the research team, or at least consultation from people with lived experience, so that the methodology makes the most sense from the get-go, so that it's integrated all the way throughout. And in terms of equity, we are realizing as a field that like many fields, we've been sort of reflecting the general population's assumptions and blind spots to structural racism. And so there are ways to actively promote equity in suicide prevention, to use the findings related to different populations' risk and prevention. Of course, we need to have much more investment in the science, and that is why AFSP made diversity one of its research grant program priority areas. But just to say that it's not that any aspect of identity on its own is what leads a person to have increased suicide risk. It is the experiences that surround that identity. So if we're talking about different racial ethnic groups, or sexual orientation, gender identity, or the intersection of several identities, along with let's say having a mental health condition or carrying some suicide risk, all of those are aspects that we need to become much more proactive and supportive, and reducing barriers and allowing it to be actually safe to seek care and effective. But even things like introducing a trauma-informed approach into a school, or into an employee assistance program, into a workplace. It goes far beyond now just introducing trauma-informed thinking into healthcare. We're learning about ways to do that across the board. So let me now try to wrap up quickly with just some last highlights in terms of prevention strategies. The science really tells us that we need to change our language, so the term commit suicide doesn't make sense anymore if it truly is a health issue. There are universal strategies in education that can be done, and many organizations have this as a priority. At AFSP, we have numerous programs. Our basic 101 program is called Talk Saves Lives, which can be implemented really in any setting. We even have a specialty one for corrections system staff, and for people who work with older adults or with LGBTQ populations. We need to work with faith communities and have some efforts doing that. We have a partnership with the JED Foundation and the Ad Council that produced an ad campaign for youth called Seize the Awkward. Please do check that out if you haven't seen that. Really a remarkable thing that is another indicator of societal change and stigma reduction is the fact that OSHA has just last month, or maybe 2 months ago, announced at the national OSHA level that suicide prevention is now a workforce health and safety issue, and actually have developed what they call an alliance. They don't use the word partnership with AFSP, and we'll be working with them towards a comprehensive suicide prevention approach in any workplace that would like to engage with that. And of course, that's because we've been doing that work already with numerous workplaces, including some of the organizations listed here. And the reason I show our partners and have the yellow circles is just to show that suicide prevention is now happening, of course, within the mental health space, but far, far beyond that. If you look at these types of organizations who have external and internal facing ways that they're making some progress around mental health and suicide prevention. I mentioned the importance of postvention, the aftermath of suicide. That's oftentimes a way to mitigate contagion, thereby preventing suicide, but it's also a way that organizations become much more motivated and ready to take next steps in terms of implementing suicide prevention. These are the postvention guides that I mentioned, so don't ever feel like you have to figure it out and make it up as you go. This is a really tricky moment. It is a crisis moment after losing someone to suicide. But if you have a role to play at a school, a workplace, a health system, we have these toolkits to provide very granular guidance and templates about how to work through that moment. In the clinical arena, there's a lot of change going on with regard to suicide prevention. And when I think about use of technology, I'm actually thinking both at the community level, meaning, as I just mentioned, universal strategies that can be things that all of us are exposed to and throughout the entire lifespan, even potentially, that technology may have an impact on. But it also means that technology can be harnessed within healthcare, of course, to reduce suicide risk. And there's a number of different things that can be done. So from a health system standpoint, there is now a call to action. The most famous sort of branded framework is called Zero Suicide, although it really represents the best of the science to say, if we do this type of screening and we respond to positive screens in these ways with some suicide risk assessment, with some education for the person, for their family when possible, if we provide them with resources, follow-up, appropriate referrals, if we put caring communication and contacts into place, if we counsel them on lethal means removal from the home, even on a temporary basis, and if we use safety planning, those are all ways that populations, high-risk patient populations, suicide risks are demonstrated to be reduced when a health system makes this a priority. So we no longer think about this on the individual clinician basis alone, because that really doesn't work to try to do all of this, in the middle of a clinician's busy workday. So again, I think about the way that technology can be used in so many parts of this system-wide approach to preventing suicide, both in terms of piecemeal strategies, for example, with safety planning, but also in terms of bridging care, in terms of how people receive those caring communications. So let me just, I've gone over, these are the main pillars of what are considered brief suicide preventive interventions in the clinical arena: safety planning, lethal means counseling, timely referral, and of course appropriate and real referrals, which can be a challenge still. A lot of these are big system issues. Resources like 988 but other more local resources and more personalized resources, and that caring contacts approach can be something that's systematized so that it's not on the individual clinician or even team to have to think of doing that, but that the system is actually automating sending out of carrying messages to high-risk patient populations. There are specific treatment modalities that have been developed and studied specifically for high-risk populations, meaning after they've already attempted suicide and they're coming out of a psychiatric hospitalization or being discharged from the emergency department. So I won't go into all of these now, but just know that there is a growing list of modalities that, again, we're in that awkward transition stage in a way between knowing about these, but actually having them be implemented and accessible to families and people around the country is where we are and where the action is. And at AFSP, we do have a project called Project 2025 that is aiming to reduce the national suicide rate 20% by 2025. It started some years ago. But it's focused on implementation and action and then measurement of those outcomes. So I will close and before opening it up for hopefully engaging in a robust discussion with you all with some takeaways that we know that science is shedding light and that societal norms are changing. We all have a role to play to deepen the effectiveness of all of that. Opening minds up is great, but not if it doesn't lead to behavior change. And that's what I mean when I say the deepening of mental health literacy, where it can actually be applied in our personal and professional lives in all the roles and all the hats that we wear. And looking at that also from a societal and population health perspective. To prevent suicide, and we really need to have programs that are multi-pronged, that are strategic and thoughtful and sustained over many years. And that is some of the hardest parts about implementing suicide prevention, is that it's not something that we can do in a silo. It does require multiple sectors to come together. Educators, health systems, clinicians, policymakers, workplace leaders all have a role to play in suicide risk reduction. Limiting access to lethal means is one of the most robust findings in the suicide literature that does save lives. So if someone comes to you and their loved one or their child is suicidal, two things: help them make their home environment safe and rid of easy access to any lethal means in the home, even if it's on a temporary basis, and help them learn how to have a caring, supportive conversation. At AFSP, we have something called #RealConvo, and you can look it up online. It provides actual tips on how to have these supportive conversation, because believe it or not, we hadn't built that kind of literacy. And interventions that are effective in reducing suicidal behavior, as mentioned, are being developed, and we need many more, of course, but now also it is time to implement them at the broadest scale possible. And here's a list of just some resources in case you're looking to take a deeper dive to learn more. There's a picture that shows the book that I published last year that tries to capture all of this, and of course, a lot more in terms of clinical guidance. A number of websites. I will highlight that there is a new screening tool that's been most recently validated by the NIMH, developed and validated, called the ASQ. And it is freely downloadable on the NIMH website. So we can add that to the list of tools in addition to the Columbia tool and other screening and assessment tools. So I will end there and stop sharing here.
Thank you so much, Dr. Moutier. That was really a terrific overview of where we are in suicide prevention, the most important problems that we're tackling right now. And I think, it's difficult to talk about suicide prevention and suicide in general without this feeling of, I think, helplessness that we often have, given it's such a catastrophic outcome. And so I appreciated, your talk particularly, because I think there was some hope in it too, right? Some actions that people can take across levels and across their different roles to help prevent suicide, both within families and socially. So, thank you for taking that broad perspective. We've got several questions that have been coming through. I have one question just to start us off, and then I'm going to dive immediately into the audience questions, if that's okay with you.
Yeah.
You mentioned this really encouraging fact that stigma is going down, that people's openness and willingness to talk about mental health issues and seek help is maybe at an all-time high. The perception that, you know, there's something wrong with you if you have a mental health challenge is going down, but we're not seeing that translate into really, you know, big decreases in suicidal in death by suicide or attempted suicide. Why do you think that is? Like, what is the disconnect between those two changes? Is it a lag effect? What are your thoughts on that?
Sure. I think about other previously stigmatized, poorly understood, complex health outcomes. And so if you take cancer as one example, that science, you have to lead with science, in my estimation. You shed light on what are the causes that helps dispel stigma. But so right now we're at we've done a great job, I think, and COVID helped in a weird way. The silver lining was that stigma went way down. So help seeking did go up, but trying to access mental health care, if that's the only change that happens, that will not be enough. Suicide prevention is complex, and there are things that we need to be doing in our everyday lives with our family members, with our coworkers, in our policies at work and at school and in faith communities, so that this can be a fully, optimized situation. And I think part of the crux of it, I call it deepening mental health and suicide prevention literacy. So the literacy piece being the lag, the big lag right now. Most people I find out there who are very, very interested, might see themselves as advocates, they are still struggling to really, and look, it's a complex topic. And so it is a real challenge to boil it down into, more doable strategies, let's say, for a workplace leader. But I have to say, we've been able as a society to do that quite well for complicated other health outcomes like cancer, HIV, AIDS, a number of things where it has to be multi-sectoral. So it's attitudes, but then it's care, but then the caregivers have to be competent, and there have to be treatments that actually work. And again, far beyond just the clinical pathway. People should be able to get peer support and family support, just like they do if they have cancer, for example, if they've attempted. And right now there's still a big disconnect. So we say our attitudes are open and that's, we don't have stigma, but then when we're faced with what do we actually do in the workplace once, somebody has attempted or has revealed that they're in a crisis, are we looking at it through the lens of health, or are we looking at it from a getting confused with discipline and performance issues? There's still a lot of confusion even within the healthcare space of training physicians and the medical space, which is where I come out of for suicide prevention efforts for our own, though less focused on patient care.
Yeah, I mean, it sounds like, based on what you said, we are at a moment where the sort of advocacy and policy change work that you're doing is both especially important, but also maybe even especially able to be effective in a way that it might not have been 10 years ago.
Yeah, I do feel that because this isn't, a simple do X, Y, and Z. If we made policy changes and they didn't understand how the implementation needs to go and what a level of appropriation for funding stream needs to happen, it will fail. And I'll say we've had a national suicide prevention plan since 1999 that has been so far very poorly implemented at any broad or sustained level. You can look at the CDC's state by state sort of report cards, if you will, on their state-based suicide prevention implementation. And it is highly variable all over the map. Now, some states have been doing it and are incredibly sophisticated, but others are just basically starting.
Yeah, right. So speaking about implementation, the fact that we are a digital technology focused conference, what are your thoughts about the way digital apps or tools, whether it be phone based or screening tools or real-time data, feedback coaching, all of that for mental health providers and for patients themselves, how does that potentially stand to change the landscape and change the sort of public health crisis that we're in?
Yeah, I mean, it is huge. And in my estimation, we need much, much more very specific evaluation related to not only mental health outcomes, but suicide risk reduction, because believe it or not, they don't always track exactly the same. And what we've learned in the scientific field of suicide risk reduction is that a modality is maximally effective if it's developed with suicide risk reduction in mind and studied in that manner. And so if you think about it from that standpoint, we have, there's so much out there. And it's not to say that anything that enhances resilience, mental health, social connection isn't helpful. It's all positive. But from a suicide risk reduction standpoint, if an app or a tool is going to specifically want to focus on that, it needs to, in a very specific way. So in addition to diversity, the other research grants priority area for AFSP is technology, actually. And that's because our scientific council says we need much, much more to focus on this.
Right. I mean, so kind of related issue, we have this crisis of an overwhelmed mental health care system across the US. And, we want to be able to implement suicide prevention interventions that work, and hopefully with digital accessible means. But is there a fear that if we try to do this too broadly with a lack of mental health resources, that maybe the support won't be there, these interventions won't be effective, and maybe we can even cause harm by prematurely deploying things at scale that, there isn't the resource to support?
Yeah, I mean, it's a major problem, and healthcare and mental health care and diversity within the mental health care workforce are all policy priorities that are top and have been for AFSP and NAMI and Mental Health America, for all of our groups at the national level for many years. And it is a dire situation, no question about it. Yeah. There is, though, the fact that treatment is essential for some. Peer support is essential for all of us. Right. And so I would look at it in sort of a layered way. I think harm could come if harm is happening already. Harm is happening when, when people are taking the risk to speak out about the fact that they're having suicidal thoughts, and that it's not being met with ongoing support and being connected with things that do help over time. But remember that some people are finding the help that they need. At AFSP, we have to be very big tent about all of this. And so treatment and support is what we recommend is whatever works for the person. And so of course we do have evidence-based modalities as well that are highlighted. But again, the trouble is, who can access CBT for suicidal persons, and who can access full DBT at this point, or CAMS? And it's not to say we're giving up. All of those things are all of efforts that we're pushing on. But I wouldn't get hung up on, well, we should wait. What I would do is whatever your world is, if you're looking at a certain digital technology that has the potential to have broad use and application for suicide risk reduction, then team up with a suicide researcher and apply for a pilot grant from us, or please do turn your attention to this. We do need that science so much.
Right. And I mean, I think the patient communities and families of people who are affected by suicide, waiting is not an option.
Exactly. That's right. Mm-hmm.
We had another audience question about social media and suicide prevention, and what is the role of social media, both as a spreading contagion, but also which platforms are best for prevention. I would add to that, which platforms might be not necessarily doing harm, but you think about people who are promoting non-evidence-based practices in things like
right.
That. So,
yes.
What do you see as the role of social media in all of this?
Well, there's obviously a research literature that's very evolving, and like everything in suicide, the suicide related field is complicated. So there are clear detrimental effects especially for some youth who are finding some of the core common experiences of especially heavy social media use, with regard to feeling excluded, with regard to that human trick we play on ourselves with the comparison game, which leads to no good for mental health or those who are at high risk for suicide. But there's no question that there are also these really positive, impactful things happening that the suicide, that the research literature is bearing out in terms of social connection and support. Contagion is definitely a potential risk. And so by the way, one of the tricky things about our work is to normalize help seeking and distress, but to never normalize suicidal behavior. So even the difference between suicidal thoughts and suicidal behavior. So it's just one of those nuances that obviously in the social media arena, where a lot is just off the cuff and tends to be sensationalized. But I will say that in our work with a number of the big social media platforms, there's lots of issues there. There's lots of challenges and problems. Many of them are trying in different ways to have some safeguards. And, I don't think it's enough yet, obviously. Yeah. And I will also just point out, there are also some websites that are just frankly pro-suicide. And that has come to attention in terms of even now some legislation that's on the table. So it is kind of a new day. And I think, again, the challenge here is, how do we translate that science into best practice so that we can help our policy leaders and help these social media platforms to, because many of them, you can be cynical, and certainly that is a reality, I'm sure. But many of these leaders have been personally affected themselves. They are actually trying to make some change happen. It's complicated because we're always well aware too that we could be being used in a way to provide cover in a way for for-profit organizations. We are very careful about that.
Right. And I mean, it's such an interesting distinction. I mean, obvious, but yet subtle, about this suicide help seeking versus suicidal behavior, and the need to really make one okay and acceptable and open without the other. And wow, that must be a hard communications thing to need to.
Well, yeah. And there's the guidance for like entertainment content creators, news reporters, and social media sites is very, very solid and very clear about some key things of like, please avoid, like never show specific graphic methods for suicidal behavior or suicide. That is always, that's the most basic thing that's linked to suicide contagion. But then there's a lot more subtle things too of how do you encourage people to tell their stories that might even include an attempt, and certainly loss, but that's the world we live in. We have tens of thousands of volunteers who are doing that at every, one of the thousands of Out of the Darkness walks. And when we get in front of Congress, and there is a way to do it safely and effectively, where you actually inspire the opposite kind of contagion, which is to become more authentic, to be able to seek out help and take that next step. That is a really exciting thing that's happening in so many aspects of AFSP's network. And that's, I came into this role with some knowledge and the science is growing, but it's also that the lived experience community combined with all of this, it's like a journey that's happening together. So there's a lot of like real-time learning about how it works best for application.
Right. And I mean, contagion, you talked about healthy grief earlier, you think about a contagion of the healthy grief contagion. There are ways in which contagion can be really, really positive. It's the right messaging, right? So another question that came in through the Q&A was around the decentralization of mental health care as a result of telemedicine-based platforms. So what has that done for suicide prevention potentially, but also in a way that maybe, people are cut off from the high touch sort of interactions that maybe they had before? So what are your thoughts on the role of telemedicine and the change over the last few years?
Well, we view it as mostly extremely positive for the potential for suicide risk reduction, even just looking at access to mental health care alone, let alone the fact that many people do find it very effective to engage in therapy or other modalities of treatment, or again, even, other forms of like addiction recovery groups being hosted online and virtual. I mean, by necessity, a lot of that had to be the case. So the fact that we were in a moment where even going for general health maintenance appointments became like something you just basically waited to do, but we saw mental health care seeking go way up during that period of time. The CDC has a household pulse survey that they've been doing every few weeks of like 90,000 Americans. So you can see based even on demographics and a bit on geography, race, ethnicity. It's really fascinating to see which groups have been seeking mental health care more, but also which demographics are having harder time accessing it. So, I mean, the telehealth thing, we've hoped that it's here to stay. We hope that the opening up for crossing state lines will continue robustly. Looking at what is billable has been certainly an issue. And then again, the science needing to take a look at what is effective and deliverable over a telehealth modality versus what isn't. But right now we're coming at it from the assumption that most of it is.
Yeah, right. I mean, you mentioned earlier the change and increase in suicide amongst Black and Brown communities over the past few years. Do you think that's to do with issues of access mostly? I mean, obviously the last few years have been very tumultuous with regard to thinking about the deep race-based discrimination we have throughout of our social and even medical systems. Like what do you think?
I think it's, I mean, like as with everything in our field, it's not going to be one reason. Right. But you think about different impacts, not just during COVID, because we knew that Black youth in particular, especially young children, but up through the teen years, that their rate of change, it's not that they have, well, I should give some specifics here. Yeah. For children age 5 to 11, and that's a very still rare event for a child that age to die by suicide. It's still in the, until about 2019, it was in the double digits across the country in 1 year that you'd have a number of deaths by suicide. But the fact that Black young children now exceed white young children, that's a never before race-related phenomenon. White Americans have always had higher suicide rates across all age groups. So, and the rate of change has been accelerating the fastest amongst Black youth. And that goes back to about 2012, 2013, long before the pandemic, obviously. So we think about things that relate to even the most basic things about changes that might be going on societally, culturally, faith communities being one of the theorized main protective factors for Black communities and other communities as well. But certainly, I think the disruptions around race-related experiences, while it's a time of advocacy and much needed, racial and social justice, a time of change, that has put it in front of people in a potentially re-traumatizing way so much more. And so it's and it's not to say we of course we have to do the right thing as a society around this, but we also need to really help protect people from that re-traumatization. But even just things like looking at the trends in firearms purchase and new gun owners, there's a story to tell there as well across race, ethnicity, as well as gender. Women were the most steep increase in new gun owning purchase during the pandemic, for example.
Yeah, wow, there's a lot to unpack there, right?
Yeah.
I think I'll end with this question because I think this is on a lot of people's minds. We talk about this helplessness that's associated with thinking about suicide, especially if you have been affected by it, a family member or even oneself. We're in a moment of policy and advocacy where maybe things can change. If you were going to give one call to action to everyone who's in this room right now of what to do to help push that forward and, create a future where suicide is less of an issue than it is now, what would you say?
Well, if you're so inclined, our policy team makes it really easy. So you can go to afsp.org and we have a policy action center where you can sign up to get the alerts. And in about 30 seconds, every time our team, which vets all the legislation and puts that call out only when it's really, a big opportunity. Yeah. our policymakers, there's, it's not always perfect, but I will say what I've seen happen on the Hill and at the state level is a change over these years. So they are listening. They understand that their constituents are demanding these changes now. So that's one just, policy level thing, is to sign up to be an AFSP. We call them field advocates. But I would say the other thing is just to think about the people in your life and develop a lens for suicide as a health issue, just like we do for other things, which can have different implications about how you have dinner conversations. Instead of, as a parent, it's hard, even for me, to have learned to get out of the mode of just sort of like always being in that reactive and crack the whip mode, but actually setting aside time to listen and to really take an interest in what their worldview, what's going on in our loved ones' lives, and opening up that space for connecting.
Yeah, very well said. And, I encourage everyone to go ahead and sign up to be field advocates for ASFP. That sounds like a really wonderful thing to do. Thank you, Dr. Moutier. This was really terrific. Appreciate your time. I think people probably learned a lot from your keynote, and, thanks again.
I hope so. Thank you so much for including me. Conference is awesome.